Hi, it's Matthew Holt. It is the April the 9th edition, somewhere in the odds of about a month into the to the COVID-19 crisis as it's happening in the US. Wuhan, China, got let out of lockdown after 74 days yesterday. And it's today's episode of THCB Gang. With me today, we have a new guest in the lineup, Elizabeth Claiborne, emergency room doc and expectant mum from the Baltimore, the Maryland area, Prince George's County. Going to be talking a bit about her op-ed in USA Today and her experiences on the front lines. And with us, Sarab Jar, Rograd from Philadelphia, Anish Koga, who we just bumped in. Hi, Anish. Make up our clinical team and our non-clinical health wonky folks. Jane Saracen Khan, healthy thinker from all the way from Philadelphia, which looks like she's in Rome. And Ian Morrison, rounding up healthcare futurist, rounding up the people with the funny accents in today's THCB Gang. They should all be popping up on the screen right now. Well, welcome everybody. I'm glad to see you all here. We're going to start with Elizabeth. I need to unmute. There we go. Elizabeth, just welcome to the gang.
Thank you for having me.
Wanted to ask you a couple of things. You are working on the front lines as an ER doc, and the first ER doc we've had on the gang. So welcome. You're also an expectant mum, and you're working as a professor at the University of Maryland. Just tell us real quick about your experience, then I want to ask you a bit about your USA Today piece.
Yeah, absolutely. So, we've been getting a lot more busy in Maryland. There's been a little bit of chatter in the news about DC being a possible next hotspot. And where I work at University of Maryland, Prince George's Hospital Center is just outside of DC. And so we've been seeing an increased number of really sick people. Our ICU recently had to initiate the first phase of their surge protocol. So for someone like me who's pregnant and going in every day and knowing that I'm getting exposed to COVID positive patients, it can be nerve wracking, and I'm just taking it a day at a time and being as careful as I can be.
What's your protective clothing situation, protective equipment situation? I've got my very fancy mask from the fires we had here a few years ago, which I'm now wearing outside. I'm supposed to go jogging in it, but we've had a lot about access to to safety equipment for workers in hospitals generally. What's your situation?
So, I think we're taking it day by day. We certainly are not 100% comfortable with our reserves of PPE at the hospital right now, but our administrators have done a good job of making sure at least every day when we show up, we know there's enough masks, gloves, cleaning supplies, gowns. And we had a local donation from a store of respirators. So right now, every emergency provider has a full-blown N95 or P100 respirator, which is much more secure. And something that can be reused. And for someone who's pregnant like me, just makes me feel a lot more comfortable when I'm working.
Yeah, well, our things are all crossed with that. Okay, so last question for you, and then we'll go do a round the horn with the gang. Is you just had a piece in USA Today about DNRs, but you had a new expression with DNRs. So tell me you haven't read that. What your expression is and what you're suggesting.
I've been trying to bring more awareness to the importance of advanced care planning. So I think, in the United States, I would consider us to be almost a little emotionally immature when it comes to preparing yourself for having in-depth conversations with your family and healthcare provider about what you'd want done at the end of life. And this pandemic is a perfect opportunity that highlights how important those issues are, because if you do get really sick and show up in the ER, we have minutes to make a decision. And so it'd be helpful if you've thought about what you would want done or what you wouldn't want done and shared that with your family and your healthcare team so that everyone's on the same page. And I know a lot of people are afraid to say that they wouldn't want to be resuscitated because they think that you wouldn't receive any medical treatment, which is a misnomer. There's still a number of things that we do for people in those situations. It just means that your goals of care might be more focused on the quality of your life, controlling your symptoms, rather than doing things that prolong your life. So I always recommend that families think of DNR instead of a do not resuscitate order, really correlating much more to having an opportunity to die naturally and with respect. So that's the way that I think about DNR.
Great phrase. I'm glad you got that one out. All right, let's go around the horn. I'm going to start with you, Ian. What have you seen in the last week that has come to your attention, you particularly noticed?
Well, I mean, I'm one of the non-clinicians here, and I've found it kind of ironic, given we're not even at the peak of the surge on the health system and the sacrifice that all of you clinicians are making. not to even mention the death toll and the horrible experience for families. But I've been sort of struck that the zeitgeist has already pivoted to the recovery and how we get back out. And, you know, I think that planning work needs to be done, but I've been kind of amazed at the prematurity of all of that. And I think there's a certain amount of, oh, we're past it now, and we just got to do this shoot to the moon explosion. And I've been working with some people just trying to think through some of the longer term scenarios that I think it is important to do the planning, but I think we may be getting ahead of ourselves in the conversation until we solve the problem that the front line is really dealing with, and all the issues we've talked about in this session and previous weeks. So I think we still got to keep supporting our caregivers and think ahead, but don't get ahead of ourselves.
All right, Jane, what do you notice?
Yeah, well, I agree with Ian and Elizabeth. Thank you for the DNR discussion. We dealt with that with my own family. So I thank you. I bless you. For me, working a lot on social determinants of health and health justice over the last decade or more, I'm absolutely astonished that the president and mass media just starts to talk about the fact that African Americans are dying at a higher rate than white people. Lordy, I'm glad the issue has attention, but does it take this? It took this issue to bring that up. So it's unbelievable. I've never heard the word social determinants of health spoken on CNN, MSNBC, Fox, and other places as much in the last 24 hours as I've heard in a decade. So that's my astonishing moment for the week.
All right. Saurabh, what do you notice this last week?
Lots of things. I think the information that's coming from preprints, people wanted preprints because they didn't trust the peer review process, is overwhelming everybody. There's so many counter theories that are going around. It's not quite conspiracy theory level, but still there are lots of these bubbling ideas, such as, do patients with ACE inhibitors do better? Do they do worse? Is this a specific thing that coronavirus attacks? Does it attack hemoglobin? Does it make the whole oxygenation a little redundant? So there are all these theories that are bubbling out, and it's going to be very difficult separating the signal from the noise over here. The other thing that really struck me was I had a chat with this intensivist who also works as an emergency physician up in New York, and he told me that the ICU death mortality, he was quoting figures around 20 to 25%, and it seems that if this illness is this illness has multiple phenotypes. Is it Chris Cuomo, who's the guy that comes on CNN and keeps arguing with his brother? Chris
Cuomo, yeah.
Yeah, that's the guy.
Cuomo.
It's him, where he just looks like he's in the best of health with COVID, and that's very fortunate for him. Happy for the lad. And then there are others that make it to the ICU and who have very high mortality. So the spectrum over here is quite dramatic, and it's not just in people who have comorbidities. It seems to be in young, fit people. So this virus is a little temperamental, a little unpredictable.
You could put it that way. My friend JL Neptune has been doing he's in New York. He's an MD. Had a series of videos out on his experience, and he may be the not youngest. He's in his 40s, but one of the fittest guys I know, and he's been really knocked on his rear end by it. I've been challenging him to, and I've just taken up running, so I've been challenging him to a race. Although he says he can now beat me again, so we'll go on. Anish, what do you notice in the last week that's really piqued your interest?
I think the most interesting thing to me has been the models that describe what should be happening, and then the discrepancy between what actually is happening. Clearly, we've made some pretty big moves, and we're causing a lot of pain to folks who had, with possibly good reason, partly because of the scale of damage that the models have said. And how those models are updating, what the real world data is. Those have been really interesting. I think a lot of the models have used what happened in Italy and what happened in Italy as to give a sense of what our needs would be, what the death rate would be, and it's been certainly very interesting to see that that could be that the actual numbers as they're playing out, and really across the United States, how things have gone. The idea was, just 2 weeks ago, the idea was that every major metro would have something like New York happening. That clearly is not happening yet at the same scale. New York, New Jersey is together. That New York, New Jersey metro has 11,000 new cases a day, and we don't seem to be having that type of outbreak happening in most of the rest of the country. So.
Yeah, I think this is a great point. I love that I've been here on this one. I do have to get in my favorite news story of the last week, which is, despite everything, the healthcare system can do what it does. My congrats go to it's called Frodent Memorial Lutheran Hospital in Wisconsin, which has been serving out process servers without giving them PPE to sue people for unpaid bills. Really, they got their PR hat, right on. Okay, but let's start. I want to start with the three of you clinical folks about this issue around the models and what we're expecting, because we in the Bay Area have got this new Sarah Cody, who's the Dr. Sarah Cody, who's the Chief County Health Officer for Santa Clara County, who's the one who shut us down, as it shut down the Bay Area essentially. And now there seems to be very little activity in San Francisco Bay Area hospitals, despite the fact of our proximity and travel to China. You obviously got the New York City thing, which may be peaking, may not. We don't know quite where that is. And these models are kind of all over the place. And then talking about conspiracy theories, Saurabh, you've got all these people saying, well, if you look at the regular deaths by pneumonia, they're down, so we're miscounting COVID. Other people are saying, oh, we're not counting people who are dying at home of COVID. So maybe until we get to the end of the year and can count total deaths, that we even know what the impact was. But nonetheless, impact on the health system, certainly in New York and Seattle, was pretty considerable. So I'd love at least the three of you, starting with you, Elizabeth, to comment on where you think we are in the cycle and how bad this really has been, going from the people who had the president's version, it's going to go away in April, to all the way to people saying it's going to be take out, as Anish was saying, take out the healthcare system across the US like it's done in Northern Italy. Elizabeth, what's your comment on that?
So one thing that I would add is I think people have to keep in mind that we are still not robustly testing people. So when I go in, I literally am told by administration every day that this is our reserve of tests. You are only to test people who are acutely ill and being admitted to the hospital. So that means the vast majority of people that I'm seeing who I suspect are COVID positive, and even people who we would normally admit to the hospital where we're stretching our kind of bounds of what we think is safely discharging people home. So people that have saturations of oxygen that are much lower than you would normally let go home, but in this situation, we're letting them go home. They're not even being tested. So the raw data that we're getting in the United States is off.
Yeah, but that was the case everywhere. That was the case in China. The series shows that 40% of folks weren't test positive, but were clinically decided to have COVID. That was the case in Italy, where only the people that are being tested are the people that are sick and that are being admitted into the hospital. That's why they say the Italy death rate is something like 14% or some crazy number like that. So sure, I hear that all the time, but I think when you're talking about comparing us to Italy, to Wuhan, I think it's probably somewhat similar in that all of those places that are kind of epicenters, New York City certainly is one of those examples, is that we're all across global, different epicenters, we're all testing basically the same people, which is the folks that are sick enough to be symptomatic. And if anything, certainly New York, if you look at the per capita testing, certainly that's the highest per capita testing anywhere in the world in terms of how many people you're testing. So I don't exactly know. It's possible that we have, it's certainly the case that we have a lot more test positive than what we actually have, what's actually the number it is that's showing. But I think the real thing in terms of whether we're escaping or not is the hospitalization data in terms of, all right, so it's been what, 12 days, no, almost 2 weeks now since many places have shut down. And, where is the surge? And we certainly have various different places there is a surge: Detroit, Louisiana, outside of Miami, now for a little bit in Philadelphia, but certainly nothing like the surge that we're seeing in New York City.
Elizabeth, what's the, right in your ER that you go into every day, what are you seeing in terms of numbers coming in compared to what you had before? Where are you in PG County?
I would certainly think we have a drop in our lower acuity patients. So a lot of people who are healthcare providers noticed this whole quiet before the storm, where it was really a ghost town for a while, which is amazing for us, because it's like, where did all these people go that always have such urgent needs that they have to come to the ER and see me at all times of the day? Those people have really disappeared. I think a lot of people are afraid to come to the hospital unless they really feel like they're sick. And even I think in general, people have gotten the message that you shouldn't be presenting yourself unless you are having serious symptoms and need to be admitted. But I have seen in the last week that the acuity is picking up. So although we haven't initiated surge protocol for the ER, we initiated the surge protocol for the ICU. So our ICU is filling up. And as we know, a lot of people who get intubated and are put on, ventilators for this illness are on vents for a long time. A lot of them do very poorly. And so I think that's why you're seeing the ICU kind of being overwhelmed in several hospitals.
Saurabh, you usually have a comment about where we are in the sort of conspiracy theories versus the models. Can you
Well, I think there's conspiracy theory, and there's also this dogged search for the truth, which really is the search for the denominator. And there's a lot of arguing. What's the true case fatality rate? What's the we need the entire denominator? Is it 2%? Is it 2.5%? Is it 0.6%? And all of that's irrelevant, because even though we don't know the true denominator, the numerator speaks for itself. And so you just have to step back and say what's actually happening in New York, what happened in Lombardy, what happened in Seattle to a certain extent. This is not normal. We've had flu seasons, and you don't have hospitals being overwhelmed like this.
You don't have refrigerated trucks outside hospitals.
Right.
Bodies, right.
I thought it was an episode from Dexter for a moment, but yeah, no, it's real life. And so this is surreal. And I think the people that are quibbling about true case fatality rates because we want to be scientific, I think are missing the point. The point is that whatever that true rate is, it doesn't matter. The hospitals are getting, they're getting beaten up. Healthcare workers are in a state of panic. Everybody is overworked and stretched to the limit, beyond the limit. People are talking about not resuscitating, changing their CPR protocols, resuscitation protocols. They've done that in the UK as well. So this is not the normal flu. And anybody that keeps saying that and wants data, that's what Nassim Taleb calls IYI. You know what IYI is?
No, what's that one?
I think it's
intellectual yet
idiotic, or idiotic yet idiotic, something like that.
Intellectual yet idiotic.
Intellectual yet idiotic.
Intellectually idiotic. We could have a podcast all about that, I think.
And numerator speaks for itself, and there's no point getting into arguments. Another familiar argument is, well, what about the number of people that are dying from road traffic accidents? Well, look at your peak RTA deaths. Were the hospitals overwhelmed? I mean, in radiology, I do a lot of emergency radiology, so my workload is direct correlation with the trauma and ER. And over Christmas, in January, it gets very, very busy, but not overwhelmed. There's still flow to the floors, and this is a completely different scale altogether.
And I would also say what's different is we see a decent number of younger people getting really sick, and there is not a good consensus among the medical community to help us predict why certain young people are doing so poorly. I mean, if you look at our ICU census, there's 40-year-olds there, 30-year-olds, a lot of people in their 50s. I mean, 50 with some multiple comorbidities certainly puts you at risk, but those aren't patients that we would normally expect to be dying from a viral illness. So it is unique. It is a unique set of circumstances that, regardless of the numbers, you're right, is different and unprecedented and is overwhelming us in many ways.
So I'd like to switch gears slightly. There are two big topics I want to raise in the rest of this, and obviously you guys can raise anything you like, but one of them is, more like what's the healthcare system going to look like later out the other end of this. I know that Ian's been doing, and Jenny been doing a little bit of work on that. And then there's the other one, which is the sort of the idea about what does immunity or herd immunity look like. In California, we're both talking about oh, we shut down early, weren't we so clever? Well, and then that's prevented the surge happening in San Francisco. But also, did we really have it in November and December? Because were there people from China here who already had it? And, you know, I know in my family, my wife had a really bad episode of the flu, even though she had a flu shot during late January and February. And maybe she had, you know, that kind of story as well. And there's real conversations now about, you know, and one of my clinical friends here will help me with the thing. When you take a blood draw from somebody who's had it and you give that plasma to somebody else, I know that's starting to happen as well. What's the technical term for that? Come on, you guys have got enough years in medical school to tell me what that's called.
A blood draw?
The blood draw when you've already had it, and then that plasma gets used for other patients. It's a treatment.
Infusion of plasma infusion.
Right.
Plasma infusion from recovered patients.
That's it, right? Exactly. Anyway, so just on that topic, what's our sense of the sort of potential scale of testing? We don't have, you know, to some extent, there's no point getting tested now because, as Saram says, you're going to be at home and fine or not fine. You've got the guy like Cuomo, or you're going to be in the ER because your symptoms are bad enough. But when we start thinking about, you know, relaxing the stay-at-home laws and what have you, we are going to need to know more. So what's your sense about, you know, that kind of testing and where we are in the process of being able to understand who might be immune and who might not be?
So I think, I mean, that is like a fervent topic of debate right now in terms of, there's a paper that just came out yesterday showing that 30% of folks didn't have a detectable IgG level, which is the antibody that would suggest that you're immune. I mean, I don't know what I don't think there's any consensus right now in the medical community about what to make of that. I think the general consensus is that if you are able to mount an IgG response to it, that you probably are immune to this. The fact that there hasn't been I think people are going to watch. Forgetting the seroprevalence, that's coming. You know, the tests are coming. Dr. Burks keeps telling us that the seroprevalence tests in terms of the antibody tests are coming at some point down the line. But I think it's going to be very, very interesting to see what happens in Wuhan, right? So the idea that Wuhan opened up, and you know, the day they opened up, there were thousands of people that were boarding trains all together in those, you know, crowded trains that we've seen in China. That is going to be really interesting to watch, to see if there is a second wave that comes, because that, you know, that'll give us some sense of what the level of immunity may be. That is also going to give us a sense of how off the China numbers were, right? Because, you know, depending, again, I'm just regurgitating what other experts that I've seen say, but depending on who you read in terms of what the R naught is, the amount of people that you need to have to be seropositive and be IgG positive ranges anywhere from 50% to like 85%. And so if there's no second wave in Wuhan, that tells you that, my goodness, that must have been a massive number of people that were infected. So I think that'll be super interesting. I just wanted to say one thing in terms of, I just looked, you know, while we were talking, because Dr. Claiborne was talking about, you know, the young people, and I see that all the time, and I think that's totally true. There's no question that for young people, this is more lethal than the flu. You know, maybe 4 or 5 times more lethal than the flu. But just to give you a sense of absolute numbers, New York City data, all right? So in New York City, there have been, as of today, New York City only, not the surrounding counties, 3,100 deaths. Of those 3,100 deaths, there have been in the 18 to 44 age range, 181 that have died. In the 45 to 64 age range, 841 that have died. So that's a significant number. But if you look at the people who have no conditions, no underlying conditions, in the 18 to 44 age group, only 13 have died. So 13 out of 3,100 have died, who were 18 to 44 with no underlying conditions. If you look at the 45 to 64 age group, 32 have died with no underlying conditions. The vast majority of people that are dying here are people with underlying conditions. About 2,100 of the 3,100. About almost 80 to 90% of the folks that are dying with COVID are people that have underlying conditions, regardless of age group. Even in the 75 and over age group, if you have no underlying conditions, the number of people that have died to date are 18. That's in the New York City numbers. So I think it really gets to the point of of the pre-existing conditions, the comorbidities that people have that make them highly susceptible to this having happen. And that, I think that also plays into the debate that Jane was talking about in terms of the data on race, right? I think there's a significant, unfortunately, because of a variety of different reasons, systemic and whatnot, there's a significant percentage of the population that is Hispanic and Black that have a number of different comorbidities. And I think, as just echoing what Dr. Fauci said a couple of days ago, that high rate of morbidity and mortality seen in the minority population in some sense reflects that high level of comorbidities seen in that population as well.
Jane, I want to get you in here on this issue of, what does that mean for the future health of those types of those populations and all populations, and what should we be doing about it?
Well, as I wrote in my book called Health Consuming,
which by the way is not all Pollyanna happiness about being a great health consumer. The first 4 chapters are terrifying.
We have to look at how we bake health into policy outside of healthcare. We have to look at food systems and education and active transportation and agriculture policy and lots of things, transportation, and things like clean air and clean water. I'm from the state of Michigan originally, so, Flint's on my mind a lot. And I grew up outside of Detroit. So this goes way back with me. I think when we start to get honest about paying real money for social services, education, especially education from the earliest of childhood, pre-childhood even, in a mother, it really goes way back to that. And people growing up on a playing field that's fairly level, but we've got decades of this not happening in this country. So I go back to that. I think the exciting thing, to segue a little bit or pivot a little bit toward what the health system could look like after COVID or learning from COVID, is that we're seeing an astonishing number of people dialing into telehealth, digital health systems, social networks, peer-to-peer networking, which Susanna Fox's article came out today in Harvard Business Review on using peer-to-peer networks for among people with chronic conditions. And if everybody uses their phone, everybody's got phones mostly, not necessarily data plans, and that's a second subject. I think we're seeing more people taking self-care into their own hands and trying to learn more from each other, and then accessing the telemedicine companies for at least an on-ramp to primary care, which is where, things have to happen. So I think we have the opportunity to learn from this moment, which is devastating, to rebuild the system. And we're seeing a lot of doctors, very traditional doctors, cottoning on to telehealth really quickly. I'm on the board of my town's free clinic. We're not an FQHC. We don't take money from anybody but foundations and people paying $5 or $10 if they want. And our little clinic, our doctors are now using telehealth and keeping patients out because we don't have the wherewithal to see anybody face to face right now. So they're doing a lot with our largely Latino population of Chester County, Pennsylvania, for self-care. So anyway, that's my rant on that.
Yeah, no, I like it. So Ian, you're guilty of sort of birthing me as the guy who said that, well, this technology stuff's going to change the world 25 years ago. Then you've been wandering around the country for the last 3 decades explaining why nothing was going to change. How, for the hospital folks and the health system folks you've been talking to, yeah, we've got this sort of surge to telehealth because people literally can't come in to the primary care office, not that they've been primary care yet. How close do you think we are to having that, to that being a real change? And what other changes in the system you think we're going to get after this?
Yeah, no, and you're right. And well, look, I think Jane said it, that this genie is not going back in the bottle, right? I mean, I think that, I'm not a clinician, but I've played golf with Bob Wachter, and I'm sort of everything I know I've sort of learned from
I've
following
journeyed through with him once or twice, so I know.
Following Wachter on the one hand, and I live right on the edge of the Stanford campus, and watching Stanford's doing a good job of doing sort of town halls with their leadership. But just a couple of things. I mean, Wachter was on our local news, and I was emailing with them. They've gone from 2% visits at UCSF telehealth to 60% in this course of a month. David Entwistle, or Dean Miner at Stanford, I think said they had a 50-fold increase in telehealth visits at Stanford. Now, it's a bit like Kaiser. Our friends at Kaiser have always used this 60% number, but that really has to do with things like prescription renewals and so forth. But they're talking about changing workflows using iPads, so you don't actually have to physically go in a room. So I don't think that genie is going back in the bottle after this. I think that is a permanent change, and particularly some of the regulations about allowing doctors to practice in 50 states using these systems. If you talk to anybody, I've got friends on the board of Teladoc and others, they're just talking about explosive numbers. So I think that's a key thing. But I did, Matthew, want to go back to the conversation we're having about testing, because what's alarming me is that, and it relates to what I said at the beginning about the reopening conversation. California Healthcare Foundation, I was on the board of for many years, did a survey of the public and just asked the simple question, have you been tested? 2%, less than 2% of Californians have been tested, according to a survey. That's not using epidemiological data. If you believe Scott Gottlieb's estimates that maybe 3 to 5% nationally, not New York, but 3 to 5% nationally have been exposed and have either succumbed or are immune, presuming immunity, that leaves a massive number of people who are both untested and wandering around out there. And I think this return to work stuff, I think what McClellan and Gottlieb and the Duke Margolis Center put out overnight is very sensible, but I find it difficult to believe we are going to pull this off. Just to give you an anecdote, my niece, who's Canadian, lives in Hong Kong. She had a baby in November, came back to Canada with the infant, and they just went back to Hong Kong because they thought it was safer there than being in North America. But what they had to go through to get back home, mercifully, no one on the plane tested positive. They actually do test people when you go off the plane in Hong Kong, unlike here in America. And they are in mandatory quarantine using cell phone controlled surveillance in their home for the mandatory 2 weeks before they can go back out. And a lot of what Gottlieb and the boys are suggesting, I think, is completely incompatible with our testing infrastructure that we have now or may have within 2 or 4 months. So I think this thing's going to take, a long-winded way of saying it's going to take a hell of a lot longer than you think. The other big issue I'd love to hear reactions to is that the bomb this has created by taking out electives and the money associated with that. Stanford talked, Entwistle saying he's down from 600 beds to 300 effective beds open. That is a massive hit to the bottom. I'm hearing revenue declines of 40%, month over month.
Yeah, well, let's get to that one in a minute. Let's go back to a bit about testing. Anish, you were trying to jump in.
Yeah, so I think I think we have to lean into the prevalence of testing. Look, if you have a fever and a cough, or you have symptoms, right, and you're tested in Philadelphia, you're tested in San Francisco, et cetera, or you're tested in Brooklyn, New York, right? We have a sense of what it is, what the probability is that you have COVID versus something else, right? In New York, in certain places in New York, in Brooklyn, 2 days ago, if you had a fever and a cough, your risk of having COVID if you have a fever and a cough is 50%, right? Unbelievable, ridiculous number. If you're in Philadelphia, that number is about 10%. If you're in San Francisco, Bob Wachter just tweeted, I think he said it's in certain places it's like 3%. So right. I think, so yes, I'm not opposed to more testing at all. Again, but there's an issue with trying to get to the scale up. Yes, South Korea with 60 million people packed into a certain place can test per capita in a way that may be that we have a lot more trouble getting to that level, right? We're 300 million people, we're we're spread out over a massive area. It's going to be really hard to, I think it's going to be really hard to scale up to be able to have like 300 million tests, say next week or 2 weeks or even 4 weeks from now. And I think, but what we have to do is we have to have representative sampling that gives us an idea of how much community transmission there is. You know, it's like the whole adage is that you go to war with, you go to war with what you have, not with what you want, right? So, okay, fine, we have the ability to do 20,000 tests a day. Would it be nice if we could do 100,000 tests a day? Great, but if we don't, then the question is, we can't just be paralyzed without having some type of capability that we would love, everyone would love to build. I think at this moment, Donald Trump would love to have 300 million tests all over the place, so he could say that, you know, he would love to drop testing labs from Air Force One in every city in order to for the show of all that, because he's a showman. So I don't think there's any lack of desire to test more. The problem is we're going to have to make these decisions without the ability to necessarily do more testing. Also, I'll point out that in terms of testing, the sensitivity of the PCR test is 60 to 70%. All right. So if you are, and you know, I'm sure Dr. Claiborne knows this, that you know that there's tons of people that are sitting in my hospital right now that are test negative but are still admitted because we know that they have COVID. There are people that have called in who I'm like, look, you can't smell. It's been 3 days. You have a fever. You have a cough. You have COVID. Is there a point to testing you? I don't know. So
right.
We need to not get so attached necessarily to the testing thing. I think we need to lean into the testing capability we have and the prevalence of and what that testing tells us about the community transmission, about the prevalence of COVID in the community in terms of deciding how to go about eventually opening up. And opening up, we have to do at some point, at some cost. So
I think that's a good point, because the tests are really not as accurate as I think the lay population really understands them to be. And we see people all the time that like come in with a bilateral pneumonia, ground glass opacities on their X-ray, and they'll test negative, and we're like, well, you definitely probably have it, so we're just going to treat you as if you did. I think we also have to be very careful about treating the United States like the rest of the world. We aren't the rest of the world for a number of reasons. And what we were talking about earlier with the prevalence of comorbidities and underlying disease in this country is why I think we're going to have a course that's much different than China in particular. I mean, their population is just significantly healthier than us at a baseline. And we have a much more unhealthy population at baseline. So modeling like what can happen in the United States based on other countries is our only source of data, and it's worthwhile to do that, but it has to be done with a grain of salt because we aren't going to be the same country. We don't function the same way. We don't have the same kind of population. We don't have the same population dynamics. There are a lot of older people here, a lot of people with comorbidities. And as you pointed out with the New York data, even the younger people who have a lot of illnesses. I mean, I see people all the time with diabetes now who are unfortunately in their 20s, or 30s. And that makes a big difference when you're thinking about how they are going to do when a pandemic like this is taking place in their setting. I think when we look forward to what's going to look, like in healthcare in the United States in general, when we come out of this, I hope that it appropriates a lens to important issues that have really been boiling under the surface for a long time. And that's specifically the health disparities issue, right? And that's really coming to the surface now because these numbers are astonishing for people. But I have to be honest, I'm not that surprised. I practice in a community outside of DC that's largely African-American. I'm African-American myself. I'm very well aware of the statistics within that population, how poorly they do at baseline. It's just that this is just magnified because of the numbers. And so hopefully we'll walk away with that, not just saying, okay, well, like, oh, well, too bad. It's really going to be more like, okay, well, what can we do to shift focus on dealing with these underlying health disparities that have set an entire population up to be disadvantaged from birth. And when we have pandemics like this, kind of bring to the forefront why that is essential to having a quality of life that you would want for any American. I also think that it has kind of brought some attention to other issues that are going to be important. So as a pregnant provider, right, you guys have probably heard a lot of data about how poorly African-American women do in birth. We have like a much higher birth complication rate than any other population. And this is even when you control for co-founders and diseases. And so I'm in that population. I'm very well aware of the risks that I have as a pregnant provider. And I found it ironic the other day thinking about what I'm going to do in this crisis. So paying attention to benefits that help strengthen our social service is important. And that relates to not just the health disparities in our at-risk populations, but just generally how we support our population in health. So we do not support mothers and families around childbirth that often. I, as a physician, only have access to a short-term disability policy when I go on maternity leave. So, you know, if I consider myself to be a well-educated, financially stable, married, and medically knowledgeable person that still finds like going on maternity leave to be challenging, I have no idea how the rest of the United States and those mothers that don't have those resources and that privilege are surviving. And even now, if I decide to just stop working, which I have the option to do, they said, okay, well, you can stop working, you'll go on unpaid leave, and then we'll initiate your FMLA for 12 weeks and your short-term disability, and that will get used up. And then basically once you deliver your baby, you'll have to come back after 6 weeks instead of 12. After I've put myself on the line to serve everybody and had this additional risk. It's ludicrous. And I just think that I'm hoping that we will not just roll over when this is all done and go back to the way that things were, that we'll use this as a learning point, and that the whole kind of positive silver lining that people have talked about with, well, we've seen our community step up and everyone is trying to help each other out and we're having this great family time, those things won't be forgotten, and that we'll have real policy that institutes change that supports vulnerable populations like women who are, you know, going through childbirth, like minorities, in a way that can be carried on into the future.
So I love your sentiment, Elizabeth, and we've had a bit of conversation about this on the gang before. And I suspect there's a bit of disagreement about what should happen, let alone what will happen here between Anishi and myself and Jane and others. But I mean, I guess the question is, right, if you look at what's going on, right yet, was it this week, we have you know, the battle in Wisconsin about whether we should be allowed to vote, whether people should be allowed to vote by mail, you know, and that's a fight about the Supreme Court seat there and backwards and forwards. You've got Sanders now out of the race officially. When he went out of the race, this is going to be one of my opening lines, healthcare, private health insurance stocks, Anthem went up 10% and the rest went up 5 to 8%. You know, even though he was already out effectively, just the fact that the fear of single payer was going to go away, and Biden's been not talking about that. I don't see, and a question of all of you, and maybe an issue agree with me on this one, I don't see, maybe Saurabh, where the impetus to actually get those changes is going to come from. Even if we have a Biden big win in the fall, we still have the Senate to deal with. I'm not hearing a lot of change from the Republicans. They have to spend money on big business. So I'm not hearing a lot of change about this safety net in the politics. Does anybody disagree with me on that?
Well, I think you have to ask yourself what needs to be changed in order to deal with the pandemic. Now, America has a lot of systemic problems. They're not unique to America. Another country that has similar disparities, actually, it's disparities on steroids, is India. Sure. And in India, the poor, they are packed together in slums, like in the Dharavi slum of Mumbai, and a lot of their economic activity depends on not there being a lockdown. But if you have if corona spreads in that area, it would decimate the poor. The difference between the poor and rich would be so dramatic that you wouldn't need any statistical analysis, any control of confounders, because it would just be too much. So this is not a problem that's unique to America. What I think is missing in a lot of these discussions, we're talking about things that have happened in the United States over the last 50 to 100 years and have accumulated disadvantage to the African Americans, and that certainly needs to change, but it will not change overnight. That's going to require a generational change. What needs to change overnight is how the CDC and other bureaucracies, the ones that are supposed to protect us from pandemics, respond. So I think we need to analyze what is wrong with these organizations. Why do they not pick up signal? What structural elements are there? Do they have too many conference meetings? Does it take them 7 days, like it takes typical academics, to get a doodle poll going? There are some big structural problems in this. And if you can't reform the CDC, if you can't reform the WHO, then there's going to be another pandemic that will come over that will again decimate all the poor people, that will again put all the economy. So the fire out here, that keeps burning, needs to be put out by the fire extinguisher, the fire people, and there's some big problems there.
The systemic problems in societies, not just the United States, but certainly other developed countries, certainly, and much more so in developing countries, of course. The systemic issues are so difficult to resolve that I think while we all want different populations to do much better than they are. I think if we go home from this pandemic and the take home message is we need to work on systemic issues in some type of hand waving way, I don't think that should be the take home message. The take home message needs to be very, very focused in on what were the steps here that resulted in this arriving in the United States and kind of exploding, and I think, that really should be the focus. So, echoing what Sarah was saying in terms of looking at what did China know? When did they know it? How do we get an early warning system set up in China? I imagine now, after the pandemic's happened and the true cost of the pandemic is so obvious, now we're going to have no problems, and nobody's going to raise the idea of xenophobia, etc. If we shut down travel from some hotspot, wherever it is, whether it be China, whether it be the Congo, whether it be India, whether it be maybe Europe. I don't know.
Maybe 7 Muslim nations that the president doesn't like. I don't know.
Right, exactly. No, but the point is that yeah. So absolutely. So I think those kind of things should go away. We just need to look at this from a pure medical standpoint. If you have an area that has a outbreak and you have information that we're uncertain about, like we had in Wuhan, right? The issue was that WHO, the CDC, et cetera, were acting on information that we just didn't have all the information. We had 60 million people, we had 80,000 cases, we had 3,000 people dead. That gave us a sense of, well, that's bad. That's worse than SARS, but it's not that bad. And they were able to contain it. And because of that, you got lulled in, and because of SARS and what happened with MERS and Ebola, you got lulled into a sense of complacency that this couldn't happen. And I think we have to really zero in on how this kind of got to America's shores, and literally speaking, got to America's shores because people traveled here from those places. And the question is, can we learn early enough to avoid this happening here? Because as I'm with everyone on this panel on trying to reduce the massive morbidity and mortality that the minority population suffers, but I think the best way to do that is going to be to try to prevent COVID or the next COVID from getting to our shores. And that's what we need to be really focused on, I think, while we continue to work on the systemic issues, which I think are much harder to solve, and there are there's deeper roots to that I don't know that there's an easy solution to.
Well, I mean, one thing that's clearly going to happen, I'll have your commentary on this one, Ian, quickly, is just, the unemployment numbers, just because we shut down, are so bad. And if we're going to be shut down, so there's 2 months of money allegedly coming from the government for small businesses, if you can get it, and by the way, it's hard to get. But the next question is, if that happens longer and it stays like that, with employment being the vector for health insurance for most people, we've been talking about single payer being, I think you told me in 1992, Ian, socially unavailable or politically unavailable to Americans. Do we stay that way? Because getting access to insurance, at the least, we're getting, some kind of healthcare is going to be a massive problem for a much bigger number of people. That tends to change stuff here.
Well, Matthew, I've been sort of working over the last week or so on these scenarios that trying to play out some of these variables you're talking about, which is really public opinion about attitudes towards coverage and so forth. I mean, there was a good, in support of it, overnight, Health Management Associates, which is a group I respect, for a bunch of ex-Medicaid director consulting group. They've developed a little model about making assumptions about unemployment rate, all the way from 3% pre-COVID up to 25%. The net effect, and I think this is about right, is that there would be no net change in marketplace enrollment under any of the 4 scenarios, but possibly a 20 million bump in Medicaid enrollment in pretty short order. That sounds in the right order of magnitude to me, and about a 40 million, up to a 40 million drop in commercial coverage, which, you ripple that through the health system, that is a big screaming deal. And the uninsured likely going up to 10, by 10 million in the most extreme cases. And that's pretty consistent with what kind of cartoonish effort I made to sort of do it in the back of an envelope. But it ties back to the race issues. The people who take the early bus work in service industries. They are the very first people to be laid off, and you know, I think that's kind of where I think this massive vulnerability is going to be exposed. And I think there will be a huge political element in the fall of, oh my God, I'm trying to do everything right, and yet here I am in a situation, unlike my old colleagues in Britain who are getting 80% of their salary and childcare, to Elizabeth's point. I think it's going to expose to a wide swath of the American public how vulnerable we all are. And there is going to be a shift potentially towards government being a solution set. And, you know, I think, but it's by no means certain that that happens. And what I've been trying to propose in these scenarios is we get a set of metrics on public opinion and so forth that we'll know which one we're in. I mean, right now it's basically, if you're a Republican, you think Trump's doing brilliant. And if you're a Democrat, you think it's the worst thing that's ever happened to humanity.
Well, forget about the Trump thing, but I think, sir, the issue, I think this serves as a great place to get confirmation bias, because, you know, you
can follow Anish's and my Twitter accounts for us to bias off each other, by the way.
I think what happens is, I think what, in terms of what we can all agree on is, I hope we can agree on the fact that the institutions that exist, the bureaucracy that existed, is what ultimately failed us. And I think then once you have that, everyone agrees on that. But then you get these polar opposite views that come up, which means that we'll be stuck in, you know, people not having any agreement. You know, the Democrats feel that, well, the only way to fix this is by pouring more funding into it, and the reason they failed is because we didn't have enough public health funding. And the Republicans think, well, look, the institutions failed. We need to get rid of the institutions. So I don't know, unfortunately, whether the pandemic will get us to.
I agree. I think as optimistic as I'd like to be, and as hopeful as I am that, you know, the pandemic sheds light on these important issues and we can move forward, realistically, the political climate we're in and how polarized it is, I don't know if we're going to see big changes in where people sit politically by the fall. I think that's why I always just harken back to where I think the low-lying fruit is. So there's some issues that I think can be politically neutral that are really important that we talked about at the very beginning of the segment, and that's the end-of-life care. So I'm a big advocate on focusing on end-of-life care, and it's because it comprises over 30% of our Medicare spending. It is not an insignificant amount of resources that we dedicate oftentimes to medically and ethically inappropriate care. And so I think we can utilize a pandemic like this to have a focus on people doing earlier advanced care planning, being a lot more robust with their involvement of that. And that's why I always, you know, emphasize people to go online and fill out their state forms or use online platforms like the mydirectives.com that I bring up, because it's so easy and it prevents so much waste in the system. And I think it's something that we could reasonably tackle in the political environment that we currently live in.
I totally, and quick on that one, I've got to sort of an interesting, that one to boasting my directives was launched at Health 2.0, so I'm proud of that. And then I want to remind people about Engage with Grace, the site that Alex Strain set up, talking about some of those questions for people for that. Right. Anish, real quick, I'm going to go around the horn.
Real quick, small point, just as a little anecdote in terms of what Dr. Claiborne was talking about, was that you know, one of the nursing homes that I go to is a nursing home where everyone has some type of significant neurologic dysfunction, meaning usually some type of high spinal cord injury. So everyone's in a scooter, and they have a Christmas formal every year. And you know, the one day I had a clinic there, the patient wasn't there, and I was like, oh, where is Mr. So and so? And he's like, oh, he's actually playing the guitar. So you know, some of the folks that are there are extraordinarily functional. You know, they're all in wheelchairs. They all have significant injuries. They're clearly disabled enough that they need kind of full-time 24/7 nursing care. And then this gentleman unfortunately got admitted to the hospital 2 weeks ago with COVID. And interestingly, you know, the kind of rush to judgment. I know him very well. I've known him for years. You know, they were like, oh, should we take him out of the Christmas formal where he's playing the guitar? I was like, absolutely not. It's way more important that he play there than come see me for, you know, for whatever 15 minutes to talk about his heart. I actually went over there to watch him play. But when he went and got admitted, right, to the hospital, the moment he got admitted, because of the superficial, the physical appearance, automatically he got admitted to the floors. There was a palliative care consult that was called. You know, and I remember being kind of a little bit frustrated, a little bit taken aback by that. It was like, why? I mean, yes, he's admitted. Yes, he's a sick gentleman. Yes, he has a pneumonia. But you have to know and you have to understand, and this is what I texted the resident and the team who was taking care of him. I was like, this is a man who was playing the guitar 2 weeks ago. I do not, you know, things get bad enough, absolutely. DNR does not mean do not try. It does not mean do not give antibiotics, etc. But I just want people to know that, you know, I want the medical community to know. I want the providers to know. I want ER doctors. I want ICU doctors. I want whoever to know who, you know, who are in the hospital all the time, who may not be necessarily seeing folks on the outside. I really want them to know that, you know, some of these folks, you know, despite what they physically look like when they're acutely sick, despite their underlying significant comorbidities, they have a very high functioning life. And, you know, we should try to keep that in, we need to make sure we try to keep that in mind so we don't buy.
I agree. And I don't think that the advanced directives works against that in any way. That's why it's important to say like, hey, I want you to do everything. But if I get to a point where I can't do these things like I enjoy, like if he gets to the point that he can't play the guitar anymore, or he can't use the bathroom, or he can't eat, or
but
whatever.
That's very hard to figure out in the ER.
That is when I would change my goals of care.
That's tough. Right. And I would say that to Anisha's point, we all have an underlying, you know, there's an underlying condition which COVID may be responsible for sort of helping finish off in some ways, but we all have that underlying condition, right? Because life is the only guarantee of death, right? Okay, real quick, just in a sentence or two, we're going to go around the horn. What are we going to see as we wrap this up? What are we going to see next week that we haven't seen so far? What do you think is going to happen in the next week or so? I'm going to start with you, Ian.
More Fauci, less Navarro.
God willing.
Don't worry. Elizabeth, next week.
I think next week's going to be really hard for several cities that have not hit their peak yet. So I anticipate a little bit of a darker days as far as healthcare providers like me next week compared to this week. And then hopefully some light at the end of the tunnel.
Jane.
To Ian's point about scenarios, I see growing political alliances between patients and clinicians as Trump states get more cases. And some people figure out that, oh, I really need medical care and don't have it.
So Rob, next week that we haven't seen so far.
Well, I think things are going to get worse, far worse. There's going to be more quibbling. Hydroxychloroquine will become the political element of 2020, when half the people won't even know what that drug does. And Twitter will be lively as usual.
I think I'm gonna just be a contrarian to be a contrarian. I'm gonna say that next week we're gonna be in better shape than where we thought we would be 2 weeks ago. So yes, I think there are unfortunately going to be more deaths. Yes, I'm going to be seeing more COVID patients in the hospital. Unfortunately, yes, Dr. Claiborne is unfortunately going to be on the front lines in some of these patients as well. But my hope, my optimistic hope, and my expectation is that at the end of next week we're in a far better place than where we thought we would be when this all started a couple of weeks ago.
Amen.
Amen.
And thank you to all you clinicians for doing what you're doing. It's inspiring.
Dr. Claiborne is really on the front lines. Me and Sarb are on like the second and third.
No, there's so many people. But I appreciate it, and it feels nice to get so much love and appreciation from everyone who understands what's going on. So thank you.
Stay safe, Dr. Claiborne.
All right. Well, let me wrap this up. I want to thank my team on the gang today. You have been listening to and watching Elizabeth Claiborne, emergency room doctor and expectant mum. You can find her on Twitter at Dr. Eliz PC and check out her editorial op-ed in USA Today a couple of days ago. Sarab Jar, Rograd, frequently seen on THCB. Jane Saracen, Khan, Healthy Thinker, and at her own blog, which I am blanking on the name of because I didn't write it down. Anish Koka from the Frequently Seen on THCB and elsewhere, and also with the CAD and Coca Report podcast, and Ian Morrison, Second Curve. I want to thank all of you. Thanks to those of you listening to THCB Gang episode 4. This is Matthew signing off, and we'll see you same back time, same back channel, 1 p.m. Pacific, 4 p.m. Eastern next Thursday.